We are in downtown Toronto for the third annual Fighting Blindness Canada Eye on the Cure Vision Research Competition, presenting sponsor FYI Doctors. And this year there is up to $80,000 available to be awarded to 5 early career vision researchers across Canada. Funds to support their commitment to eye health while advancing innovations that will help fight vision loss in Canada and potentially around the world. The members of the Voting Academy and our 3 judges have arrived, and they're ready to hear our 5 finalists pitch research projects aimed to help prevent, treat, and reduce vision loss. Welcome to the 3rd annual Eye on the Cure competition, and it starts now. Welcome to Fighting Blindness Canada's Eye on the Cure. I'm Avis Favreau, a health journalist, and for more than 30 years, the medical correspondent for CTV National News. And over the years, I've covered many stories on vision loss and the research that is so important to helping find treatments and cures. Once again this year, Fighting Blindness Canada reached out to eye health doctors, students, and researchers across the country, inviting them to share their most innovative vision research projects. The stakes: there's up to $80,000 in awards being handed out. No one will go home empty-handed, though. 5 projects have been chosen, and tonight they all get to take their shot to convince you that their work is going to make the biggest impact for vision research. The first of the 3 awards is the FYI Doctors Research to Watch Award of $25,000. This will be decided by our judges and the esteemed Academy. The second award of $15,000 is the Heathbridge Capital's People's Choice Award, where you can vote for your favorite. And finally, we have the $10,000 Inspiration Awards. Each project will walk away with funding, but only one will win the big award of $25,000. We have 3 accomplished judges here in the studio to help choose the winner. Dr. Glenn Chasen of FYI Doctors. He's an optometrist in Ontario, and along with providing primary eye care, he treats patients for laser vision correction, cataracts, and with other surgical procedures. Ramya Amuthan is a producer and co-host of Accessible Media's daily lifestyle and entertainment audio program, Kelly and Company, and she lives with vision loss herself. And Dr. Michelle Caillouette, Fighting Blindness Canada's Chief Scientific Advisor, Professor and Director of the Cellular Neurobiology Research Unit, and Chair in Retina Research at the University of Montreal. Our team went out across the country to cities where the 5 finalists work and live to hear and see their vision project pitches. Tonight, our 3 judges and members of the Voting Academy will watch those pitches one by one and then get the chance to ask each of them their key questions. Votes from the Academy and our judges will be combined to determine who is awarded the grand prize, the FYI Doctors Research to Watch prize of $25,000, to be announced later tonight. And you too can vote for the $15,000 Heathbridge Capital People's Choice Award. To cast your vote for the People's Choice winning project, please make a minimum donation online of $50 to Fighting Blindness Canada at fbcieyeonthecure.ca. You can click on the Vote Now button and you'll be able to cast your vote for the project that most inspires you. Voting will be open until noon Eastern Time, Monday, November 20th. The Heathbridge People's Choice Award, along with the Inspiration Awards, will be presented on Fighting Blindness Canada's Facebook page on Tuesday, November 21st at 3 p.m. Eastern. Our first, Eye on the Cure finalists work in Montreal, where they're collaborating on a project that tackles glaucoma. This is Dr. Xin-Xin Wang and Jiarui Liu.
When we say the eyes are windows to the soul, it's actually true. My name is Xin-Xin Wang. I'm a glaucoma specialist, a clinical researcher, and also an assistant clinical professor at the University of Montreal Hospital Center.
My name is Jiarui Liu. I'm an ophthalmology resident at the University of Montreal. And in parallel to advancing my training in ophthalmology, I'm also deeply committed to the field of research. And I also play the piano. The discipline that it requires kind of parallels the discipline that you need to have in medicine as well.
Dr. Liu is one of our rising star resident doctor. She is the great package for a future glaucoma specialist.
So Dr. Wang is a very inspiring professor and a mentor. She's always been a role model of mine in clinic, and I also know that she's a prolific researcher.
I am a mother to wonderful children. There's always nonstop action going on. You know, the appreciation I have with spending time with my family, seeing the laughters, seeing the smiles on my children's face, tells me how it could be for patients who aren't able to do that. So I do have a very busy practice, a lot of it involving seeing patients. The majority of my patients are glaucoma patients. One of the most common lines that I tell them is, whatever vision that you have lost, unfortunately, I cannot bring it back. I sometimes just sit there and hold my patients' hands. And that's the reason that we really hope that one day we can say that, you know what? I may have something that can work. It's revolutionary.
The project. Could insulin restore vision?
Imagine your entire field of vision is closing in on you until all that is left is this dark tunnel, and even that last ray of light is hanging by a thread, but there's no way to reverse it. This is the reality that 80 million people living with glaucoma is actually in worldwide, and time is running out for many of them.
We want to provide the light at the end of the tunnel for these patients and to give them the chance to see again.
In our project, we're looking at a promising new way of using insulin eye drops to restore vision in glaucoma patients. To this day, it's a feat that's not yet possible, and we want to change that. I like to think of the eye as an antenna and the brain as a TV. So glaucoma is a disease of the optic nerve, which is the cable relaying the satellite signal from the antenna to the TV, creating the movie that you're watching on the TV screen. Just like an electric cable, when the fibers of the optic nerve are broken, unfortunately there's no way of putting it back together. So you start losing pieces of the picture that you're seeing, and eventually vision is permanently lost.
For whatever dark spot that we're seeing on their field of vision, there's no going back.
The proposal. Testing the efficacy of insulin eye drops in the treatment of open-angle glaucoma. A phase 2 clinical trial.
As many people might already know, insulin is a medication given by injections to lower blood sugar in people with diabetes. But in reality, it's actually a medication that has many other talents and does a lot more for our bodies. In recent years, my research mentor and collaborator, Dr. Adriana DiPolo, through her tremendous work, had discovered the amazing results in mice where insulin eye drops were able to help damaged optic nerve to survive and even to regenerate. But obviously, mice are not humans. That's why with these promising results, we want to bring the study to our human patients.
To be able to take a drug and even a new way of administering a drug into humans takes many, many steps of very rigorous research and lots of collaboration from many different researchers and pharmacists, and it's a big effort. You start by showing the safety in a smaller group of patients, and then you move on to the efficacy, which is our phase 2 trial, the one that we are talking about at the moment. We will be enrolling adults with the most common subtypes of glaucoma. And if the safety and the efficacy results are promising, then it would set the foundation for future research examining other types of glaucoma and also in children as well. The award money will go to finance these very important and necessary steps in making this project a success.
Currently, the proven formulations of insulin are for injection purpose only, so whether it's subcutaneous under the skin or inside the vein. But we don't have any commercially available insulin eye drops yet, hence making it essential for us to come to that formulation and also demonstrating that it's something that can work.
Already, insulin in eye drops is a formulation that hasn't been used on the market before. So just using this way of administering the drops, we thought that it would also increase the local absorption of the medication and act really on the eye itself, which is what we want. And also, we always keep in mind what is the most convenient way for the patient and the safest way for the patient to take a medication, and who wants injections in the eyes every month, or who wants injections in the eyes every day. So we really wanted to use this way of administering the insulin eye drops because we really do think the non-invasive nature, the fact that it's easy to administer, is the way to go to really help patients use this medication efficiently.
Obviously, our short-term goal is to be able to bring the project forward to future phases with more patient, longer study period. But I think the ultimate goal here is, as clinicians, we want to bring this treatment to approval by Health Canada, so one day it can become an available treatment for all glaucoma patients. The benefits of finding a treatment that can reverse that damage and keep more people away from visual disability, I think it's far beyond the level of individuals, because it will mean happier families and hopefully a happier society.
This is a project that has the potential to revolutionize the treatment of glaucoma.
And so now we are going to be joined from Montreal. Hello, ladies.
Hi, good evening.
Welcome to the competition. So judges, do you have any questions? Do you want to start, Michelle?
I was just wondering about the drops. You mentioned in your video that it's never been used before, but in mice you say it works. So what's the evidence in humans that the insulin can actually reach the retina?
There are actually no human studies available at the moment looking at the absorption of insulin specifically in different eye tissues. There's actually some preclinical studies in rats, and they have specifically studied the absorption of insulin in the retina and the optic nerve, but they did demonstrate that insulin was able to penetrate and accumulate significantly into the retina and the optic nerve, and there was a peak concentration that was observed at around 20 minutes after the instillation of these drops. And there's some ongoing study on monkey models, so with eyes that are closer to the size of humans, that are advancing quite well with a collaborating laboratory. And with the incoming results from that, we'll be able to better confirm the absorption of insulin in models that are closer to those of human eyes.
I wonder if there's any data on glaucoma patients who then became diabetic and started on insulin to see if there was any improvement in their glaucomatous field loss.
There's simply many confounding factors with an eye that's diabetic. And actually for this reason to tease out these confounding factors. For the current scope of our study, we choose to not include patient with insulin resistance with diabetes so that we can get a clearer answer.
Obviously, this is a very early stage, and you're checking into clinical trials and all of that. So I'm curious about what it means for the resistance around moving forward with something like this.
We really wanted to make sure that, first of all, this is a safe way of instilling insulin eye drops in patients. In terms of the safety and the ocular tolerability profile of this way of administering the insulin, it seems very safe at the moment, and we're looking forward to the next stage of the phase 1 trial where we look at the higher concentration of insulin as well.
Wonderful. Thank you so much. Up next is a neuro-ophthalmologist from Ottawa who wants to use cutting-edge photography in the ER. This is Dr. Matthew Quinn.
I may have a bit of a bias. I think vision is, I'll go out and say it, maybe our most important sense. My name's Matt Quinn. I'm just started practice as a neuro-ophthalmologist here in Ottawa. My spouse, Meg, and I, we got married 6 years ago. We've been together for almost 15 years next month. She's in medicine as well. She practices palliative care. I've got 2 boys who are 2 and 4. I think as a young parent, having just started practice, trying to get a research career up and running as well, there's a lot of pieces to juggle, and that certainly can be challenging. Having regular weekly activities that we do with the kids, I find that very grounding. I can think of a few instances where I've had to deliver a tough diagnosis to a young person, and they have a parent in the room, and the parent is tearing up, and in those moments I feel very vulnerable, and I kind of share in that moment with the family, because as a parent, it's you can't help but empathize and put yourself in that situation. What if this was my child here? How would I be feeling? And I think I'd like to think it makes me a better doctor too. Patients I work with, one of the things they have in common is that they have some difficulty with their vision loss, the risk of vision loss. And I think that a lot of them would tell you that vision is something that we intrinsically know is important, but until perhaps we've lost some vision, perhaps until that point we've maybe taken it for granted. Working to preserve their vision and prevent blindness, it's just really enjoyable for me, and it's really meaningful work. I don't know if I had a single moment where I said, I want to be a neuro-ophthalmologist. I think that it was kind of the end result of a lot of small moments along the way, an interest in working with people and helping people, and simultaneously be involved in meaningful research where I can put my kind of natural curiosity to use and ask questions that haven't been asked before and come up with answers that can help people. I think it's the coolest job in the world.
The project. Fast finds in the emergency room.
I can tell you a little bit about the problem that we're hoping to solve here. And this all has to do with what happens when you lose vision suddenly in one eye. And the fundamental piece here is that sudden vision loss in an eye can herald both vision-threatening problems as well as potentially life-threatening problems. And so it's critical that we minimize that delay between when you lose vision and when we get an answer as to what has caused this. So currently in Canada, if somebody loses vision suddenly, they would appropriately go to the emergency room. And despite the excellent care they might get there, there's still going to be a delay of hours, sometimes days, before they actually see the ophthalmologist, who's the specialist doctor who has the training and the tools to make the diagnosis. And that delay is problematic. So this project is all about developing a tool and validating a tool that will help us minimize that delay from when someone loses vision to when they're assessed by the ophthalmologist, or at least get an ophthalmologist's input into what could be going on. To achieve this, we're going to be looking at a camera called the retinal fundus camera. This gives us a picture of the back of the eye. And this is a tool that could be used, for example, in the emergency department.
The proposal. Diagnosis of high-risk vision loss in the emergency department with fundus photography.
So fundus camera is is more or less what it sounds like. It's a camera that takes a picture of the fundus of the eye, which is the back of the eye. And this is a specialized instrument which has to take a photograph through your pupil, which is only a few millimeters in size, and taking a full color, high-resolution photograph of the back of the eye. In Canada, currently, there are relatively limited applications, if any, in terms of using this as a tool to acutely triage vision loss. So in certain centers in the States, fundus cameras are used in the emergency room. And we have good evidence from those centers that, at least in that sort of system, a fundus photograph, so a photograph of the back of the eye, can help get the answers we need quicker to start the right treatment. In Canada, currently there's no routine use of fundus photography. Certainly in our hospital system here in Ottawa, which is the largest academic health sciences center in Canada, retinal fundus photography is not used at all in the emergency room. Yeah, I think that we're starting to see that there are conditions that benefit from really acute treatment. An example of that is something called retinal artery occlusion or retinal stroke. And like strokes in the brain, we're starting to realize that certain medications, if used within hours of vision loss, may actually increase the rate of visual recovery. So now there is this impetus to make the diagnosis not in 12 hours from now or 24 hours from now, but in 2 hours from now or an hour from now, as soon as possible. Because the shorter that window is from vision loss to the diagnosis of a retinal stroke, the better the chance of starting the right treatment at the right time and as a result, regaining vision. So the purpose of this project is to validate this whole idea that we can use a retinal camera to take a picture. It gives us the right information we need to make the right diagnosis as soon as possible. The next step is actually to implement this sort of system locally within our emergency rooms and then in a broader sense within the region, and to start collecting real-world data that can demonstrate the value and the utility of fundus photography in the acute care setting as a way to improve outcomes for patients with vision loss. At the Ottawa Hospital, there are 2 emergency rooms, there are 2 separate eye clinics, and so the volume of patients who present to the emergency room with vision loss, and then in turn the volume of patients who are referred to ophthalmology, is actually quite large. So this gives us an opportunity to carry out this sort of study comparatively in a relatively short period of time, just because we're getting so many patients who present with some type of vision loss. So we're hoping over the course of perhaps 9 to 12 months, we'll be able to collect enough data in terms of enough people showing up to the emergency room who've lost vision suddenly, that we can then take a photograph of their eyes and say, well, if we were able to do this on a routine basis, what's that going to accomplish for us? The next question is, well, how do we integrate it to know when we're going to use this for the right patients at the right time without creating unnecessary burden in an already busy medical setting? So the funds are going to be used to support the purchase of the fundus photography equipment, which is at the heart of this. Getting the right camera. Again, we're looking at a camera that's portable, that's cost efficient, that's user friendly. So we've got criteria we're considering. Success in this project would be if we carry out our study and we are able to demonstrate that for patients who show up with important and dangerous and common causes of sudden vision loss, if we can accurately make that diagnosis from the photograph. If we can do that with accuracy, then we have very high confidence that if this tool is available in emergency rooms, then the next step is just implementing it in the real world setting. Thinking 5 or 10 years from now, if we're in a situation where fundus photography is available in the emergency room, someone has a retinal stroke, they go to the emergency room, the diagnosis is made 15 minutes after they get there, they receive treatment that can restore their vision. I mean, that's just the coolest thing to me.
And let's welcome Dr. Quinn. Hello, Dr. Quinn from Ottawa. Let's start with Glenn.
So I'm an optometrist, and this morning I was trying to take some fundus photos, and then I readily deferred to someone on my team who's a lot better at it than I am. What would be the plan for training the ER staff to get good quality retinal images?
We haven't selected an exact camera yet. There's 5 or 6 we're looking at, and in common, and the priority is a camera that is user-friendly. Because what we want is the triage nurse in the emergency department to be able to use the camera, the nursing student, the medical student, the emerg doc who's been doing this for 30 years to pick this up without significant training and be able to use it.
Dr. Quinn, I find this to be a very meaningful project, and I wanted to ask, why start here? Like, why does it make logical sense to, in emergency room setups, during emergency room visits, especially for eye emergencies, to go with this as the next step compared to where we are now?
I did some work during my training as a neuro-ophthalmology fellow, looking at specifically patients who came to the hospital with a condition that was mentioned in the video, retinal stroke or retinal artery occlusion. And we found that these patients usually go to the emergency room. They often show up only hours after diagnosis, but it takes hours or days before they're diagnosed. And in this particular condition, and others, and it's not only about retinal stroke, showing up to the emergency department with sudden vision loss, the problem is we're not making the diagnosis fast enough. How can we address that problem? And I think this is one practical solution.
Yeah, I think this makes total sense, and it's quite amazing to me that we still don't have that in Canada. But you did mention that there are centers in the US where fundus photography is used to diagnose. So I was wondering, what are we going to learn from your study that we don't already know from what they've done in the US, right? What are the specific questions you're going to be addressing?
This project like our Canadian project, looking at, using this tool for high-risk acute vision loss, this particular application has not been studied extensively. We'll read papers, for example, from the States and elsewhere saying, oh, it would be great to use fundus photography for this application. But if you do a deep dive in the literature, no one has actually gone and said, well, these are the conditions that we can accurately diagnose with this type of equipment versus these are ones that perhaps there's less of a role. So at the end of the day, I think what the useful output of this project will be, and this is what has not been looked at, is, what is the accuracy of this technology for diagnosing certain causes of let's call it high-risk vision loss, meaning you lost vision. If we don't get to the bottom of this soon, then we'll have lost some opportunity to treat you.
Thank you very much, Matt. Have you ever had to defend a pitch like this?
This is different. This is kind of fun.
It is.
Yeah.
We're breaking ground here. Thank you. We're going to put you in the waiting room, and we'll move on to the next scientist. Access to eye health in remote areas of Canada continues to be a big challenge. Our next competitor has a plan to change that, starting in Quebec. Here is medical student Dana Tomei.
I think my friends would describe me as somebody that always finds a space that hasn't been discovered or has a small problem in it, and I'll keep going at it until that problem is fixed. I came from a family of first-generation Canadians, and I'm also the oldest in my family among my siblings and my cousins here. And so I always call myself the guinea pig of the family. So I was the first one to go to university, I was the first one to get into medical school here. At Wilfrid Laurier, I went into health sciences, and that's where I met my friend Jack. Jack was born with a congenital disease that affected his vision. By the time that I met him in university, he was legally blind.
From the day I met Dana, she shared with me her desire to work in healthcare and impact people's lives. I was at a point in my life where I was still navigating the grief of finding out that I was losing the rest of my vision, and to have someone who understood sight loss and who wanted to do something to help others understand sight loss more really was empowering for me.
Having an emotional desire to change something or to find something and having the knowledge to do so is actually the biggest engine to change. She might be a Med 2, but she's not a typical Med 2. She's very accomplished. She's self-propelled, so she required very little supervision on the study. She wrote up the protocol herself.
The work that I have been doing and that I continue doing is because of people that have believed me along the way, and I want to make them proud, and through that I've also made myself proud.
The project. Leveling up access.
Our goal is to really change the way that vision care is provided to Indigenous communities. Right now, accessibility is 0 to none. You might have to travel thousands of miles and kilometers to get to see a provider. And we want to make sure that vision care is accessible right away. We don't have the infrastructure, we don't have the doctors out there that are able to serve. And so not having telemedicine to help, or a clinic where we can do cataract surgeries or test for glaucoma, we're really doing these communities a disservice. If we're fortunate enough to get this funding, our first step would really be to go into these communities, to travel the distance, to live with the individuals, and to understand where their perspective is. Then we'll be able to serve a community that's been marginalized, that's been taken out of the healthcare system. We're able to make an impact in our communities. We're able to go out to remote places and be able to serve these populations that don't have that accessibility that us in urban areas do. We also see that the rates of diabetes are 2 times the fold of other people that are not from the Indigenous communities in Quebec. And we know that diabetes really increases the chances of visual impairments, so things like cataracts, glaucoma, diabetic retinopathies. So all of those comorbidities that are present in our Indigenous communities are affecting their vision.
The proposal. Exploring the landscape of eye care in Quebec Indigenous communities.
The first thing we need to do is really understand what needs to be done. And this is done by talking to the people that are living in the areas, talking to doctors that have served these areas, and understanding where we can really place the resources that the most amount of people will benefit in. Whether that's designing a tool for telemedicine so that people on the ground can go into a room and be able to talk to a doctor from an urban area or around the world. Whether that's having mobile clinics that go through the communities a couple weeks a year, or simply educating the communities of the importance of eye care and things that we can do to prevent visual impairments would be the first step. Winning this award really means that we're able to get on the ground with the First Nations communities. It means that we're able to go more weeks at a time to these communities to understand what their needs are, to interview different people on the ground, and to really dive deep into what their needs are. We're creating a community where we can talk about eye care and problems in the community very openly. And to do that, we need to create relationships. And the only way to do that is if we're there, they really see that we want to help, and not just intervening just because we think it's important. A lot of funds are required for us to be able to do that. We can then move to step 2, which is coming back with this information, really sitting down with it, talking to professionals, and really honing down on what we want to do. If we need to send out an optometrist there to start prescribing glasses or doing remote cataract surgeries. So this project and the funds that would be allocated to it really would give that push to get that momentum started and to keep the momentum going. At the end of this, we want to be able to have the resources in these communities. We want to be able to serve these communities without accessibility being an issue, not to have to travel thousands of miles to see an ophthalmologist or an optometrist. And by doing so, we'll see all the vision problems decrease. I think we have a lot of hope going into the project. We've seen a lot of changes happen across Canada, and vision care has been less so looked at. And so this is the field right now that we need to really tap into. My hope at the end of this would be to go back to the initial people that we had interviewed from the beginning and say, we did this together.
Welcome, Dana. I appreciate you being here. So let's send the first question to Ramya.
Hey Dana, thank you for this. This is really such a great initiative, and I'm wondering for you what the ideal situation is.
Well, we know that 80% of vision loss doesn't need to happen and is preventable. And so being able to diagnose early on, being able to see patients while they're in the beginning stages of their diseases is very important.
It's very clear to me what you will do, right? So you want to go there and try to identify the problems, but it's not clear how you will do it. What are you going to do to actually get the information you need?
Dr. Al-Haddad, my supervisor, has been to Nunavut before and has served in the 14 different regions that we're looking at. And so there is some key people, some key community leaders that have been talked to about this and understand where we are looking to put some resources in. And so by having conversations with these community leaders and having some key people from the community being able to speak to us, and also sending out surveys to schools or to different residences and seeing what the feedback is, then that's how we're going to connect all that data together.
I was just curious how well you think the data that you're going to gather, which I assume I think is in Quebec, how well that's going to help us draw conclusions for how that relates to the rest of Canada's Indigenous communities.
I think understanding specifically this region will give us a lot of information because they are 14 isolated regions kind of across this vast area. And from that, we'll be able to extract exactly the needs that we can, the different resources that we can put in there to be able to study how it's working, to be able to spread it across Canada.
Your mentor described you as self-propelled, and I have not heard that of a researcher. You are driven?
I have some personal experiences from university where my friend Jack that everybody saw in the video, we started a club called Eye to Eye to advocate for the visually impaired, and through that we really saw the changes on campus, and all those changes really inspired me to do this because if I can make an impact on my little community at Laurier, then I think we can, by creating that community in rural areas, we can also make that impact.
Thank you so much, Dana. So if you can go into the waiting room, and we'll let you know at the end of the evening. Working on a way to halt the progression of wet age macular degeneration are our next researchers, Manjosh Uppal and Daniel Yu from Vancouver.
My name is Manjosh, and I am currently a medical student as well as a researcher here in Vancouver.
My name is Daniel Yu. I'm a postdoctoral fellow at UBC studying vision science. Vision research is important to me because eye is such a unique organ. It's the most vulnerable part of the nervous system, and I believe that is why more than 5 million of Canadians are suffering from eye diseases.
Daniel is an amazing mentor. I've enjoyed working with Daniel for the last 2 years, and I've learned a lot from him. Vision research is important to me because of my grandmother. My grandmother lost her vision before I was born. And growing up, I didn't really understand what that was like for her. As I got older, I gained an appreciation of how vision can impact someone's life. She wasn't able to actually hear about me joining vision research, but I'm sure if she would, she'd be very happy.
I'm a postdoctoral fellow working in the Eye Care Center of the Vancouver General Hospital, and I usually spend most of my time in the lab.
I think Daniel has a knack for being able to take a lot of information and coming up with a possible explanation. Daniel's the first person to come up with a hypothesis or a reason of why we saw that.
So most of the time I'm looking at the eye tissues in the lab, trying to figure out what exactly causes age-related macular degeneration. Age-related macular degeneration, or AMD, is a debilitating eye disease that causes blindness.
Our goal is to help slow down or stop the more severe form of age-related macular degeneration. I think our research has a lot of potential in terms of creating a treatment that could be affecting millions of people worldwide. And that really is something that I find truly inspiring and motivating to keep going.
The project. Halting progress.
So the ocular disease we're studying is called age-related macular degeneration, or AMD. In age-related macular degeneration, what happens is that you have these immune cells inside your eye, and they are normally harmless. But something triggers them, and then they start releasing all these chemicals towards the back of your eye, and these chemicals essentially damages the structure of your eye.
So the retina is a layer of cells that's at the back of the eye. And this layer of cells is actually responsible for our vision. And what happens in AMD, or age-related macular degeneration, is you have the retina being damaged. So in the wet form of AMD, the blood that actually leaks into the retinal layers causes rapid, irreversible damage to those cells and rapid, irreversible blindness. In order to address this, we need to be able to address the cause of that blindness. In this case, wet AMD is caused by blood vessel proliferation, or blood vessel growth. And if we can stop that blood vessel growth or prevent the blood vessel growth from happening in the first place, we can help address that problem. So at the back of the eye, there is a variety of different cells. But one particular immune cell that we think is involved here is called a mast cell. And these cells normally help fight off bacterial infections and keep us safe, but they can also cause damage to our cells. And they do this through the molecule granzyme B.
Granzyme B is a protein, or more specifically enzyme, that is known to digest important structural proteins at the back of your eye. And based on our data, it seems like granzyme B is responsible for triggering this blood vessel growth at the back of the eye.
After granzyme B causes this damage, we get leaky blood vessel growth, and this leaky blood vessel growth damages the retina, the layer of cells that's responsible for our sight.
Granzyme B could be the culprit behind irreversible blindness in wet AMD.
There's the first goal, which is to prevent the granzyme B that's already accumulated from digesting more stuff. And the second goal is to prevent more granzyme B from accumulating. And that can be done with two different types of treatments.
The proposal. The role of granzyme B in the progression of wet, age-related macular degeneration.
So we plan to suppress granzyme B activity by using two different types of drugs. One type of drug actually suppresses the activity of granzyme B specifically, and by doing so, we noticed that we can actually suppress the blood vessel growth in cultured eye tissue. Another way of doing this is to suppress the mast cells, and by doing so, we can actually suppress or prevent the further release of granzyme B from mast cells. So we plan to use both granzyme B specific inhibitor and quetiapine fumarate together, and then see if that can actually have combinatorial effect against the blindness caused by wet AMD.
So the first line of treatments would be injecting it, because you're getting these drugs directly to the site where it's being affected. However, we know that for a lot of patients and for a lot of people, getting a needle into your eye for these drugs can be a very scary experience. So we're also working on creating eye drops that have these drugs. When you add the eye drop to your eye, the drugs will move by themselves to the back of the eye and prevent granzyme B from destroying the structure of the back of the eye, as well as prevent those mast cells from releasing granzyme B in the first place. The injection will likely work a lot quicker and a lot more effectively than an eye drop would, but we also know that the eye drop is a lot less invasive and a lot less uncomfortable compared to an injection would be. So our theory, or what we are hoping to do, is prevent this from both angles, both the blood vessel growth and the scar formation. And if that is the case, then we would be helping those who would not have been helped by the current treatment. Now, the treatments that we are exploring right now would help prevent that blood vessel growth just like the current treatment does, but it would also help prevent future scarring where the other treatment did not prevent.
We plan to use our award money to update our lab equipment, and also we plan to use that money to purchase more animals for future research.
So this particular therapy that we're developing would benefit roughly 1.5 million Canadians who are diagnosed with AMD. But on top of this, there are benefits for other populations as well.
High myopia, which involves the blood vessel growth in children, and then it could also potentially benefit people with diabetes suffering from diabetic retinopathies.
I think it's really exciting that something that has an influence or effect on so many individuals, which is what wet AMD is or has been in the past. And if we can find a treatment or a way that we can help prevent that loss of vision for those people, I think that's a massive, massive deal.
It's so inspiring to see young people involved in research. And hello from Vancouver, Manjosh and Daniel, welcome. We have questions from our judges. Why don't we start with Michelle?
Can you tell us, how your approach of blocking granzyme B would be better, or if not better, how different is it?
The first thing is granzyme B inhibition or inhibiting granzyme B would happen at a much earlier stage than the anti-VEGFs are used at. So you're looking at someone who is not at the wet AMD stage, they're at a much earlier stage in the disease where you would apply this treatment and prevent it from progressing to that wet stage in the first place.
Yeah, so my question was sort of along that line in terms of, how it would be used to stop patients that have dry AMD, which obviously is the majority, from going to wet. It sounds like you've addressed that, but at what stage of dry AMD would you see this being used at?
There's these cells called mast cells that are elevated in both types, both dry AMD and wet AMD. And there's a difference there where a lot of the people with wet AMD have a lot more granzyme B, whereas a lot of the people with dry AMD don't have as much granzyme B.
I'm curious about your next steps, where you'd go for finding candidates, what phases of AMD people would have to be at for you to, for them to qualify to take part in clinical trials, things like that.
We actually started injecting this granzyme B specific inhibitors into the mouse model of wet AMD, and it's in the very early stage, but based on our preliminary data, it seems like the drug is actually working quite well. So we want to sort of kind of wrap up this early phase, and then hopefully we can move on to the preclinical stage where people can start injecting the drug into the non-human primate models of wet AMD. Yeah.
Okay, last question. On a scale of 1 to 10, how nervous were you to do this?
9. Very nervous.
Okay, thank you guys. Off to the waiting room, and we'll let you know in a bit. Our fifth and final Eye on the Cure finalist is from Toronto, investigating an inflammatory eye disease called birdshot chorioretinitis. Kirill Zaslavsky.
So I'm Kirill Zaslavsky. I live in Toronto, and I'm currently a resident in the University of Toronto Ophthalmology Residency Program. I arrived in Toronto when I was 11 years old from Moscow, Russia. Eventually enrolled in the University of Toronto for my undergrad.
4 years of undergrad, 9 years of MD PhD, 5 years of residency, and then probably 3 more years of fellowship. So it's a very long path for him.
By the time residency here will be done, I will have spent half my life at U of T. I met my wife in medical school, and we married in 2021, and we now live together, and we have a baby girl named Aubrey who is turning 6 months.
Kirill is very motivated and very brilliant, and I think that comes across easily to everybody who knows him. Science and medicine have been his 2 great passions till the baby.
Every time, she makes eye contact with you and smiles, it's like almost like water in the desert sometimes, and it's just a joy. I came here as an 11-year-old child. Like, what did I know? It was really thanks to My mother, who had the wits and the wherewithal to actually decide that we're uprooting our life in Russia and we're coming here, a country that has given me incredible opportunities throughout all stages of my training. I'm honestly not sure if anything of what I've achieved would have been possible had we stayed in Russia. I think organizations like Fighting Blindness are essential to actually advancing research in a country like Canada. As long as there are leaders in our country that recognize the value of research to the future of the country, to creating truly Canadian inventions and products, then this will continue to be viable in Canada.
The project, inflaming the debate.
We're focusing on this project on a disease called birdshot chorioretinitis. That's an autoimmune disease that affects both eyes, and even the name birdshot tells you kind of the level of understanding that we have. We look into a person's eye and it looks like someone fired off a shotgun in there. Our immune system is incredibly complex. It's composed of many different kinds of cells, and a branch of the immune system called the adaptive immune system actually has a memory. And the way it has this memory is because there are each individual immune cell, such as a B cell or a T cell, has a receptor on its surface, and that receptor can recognize something in particular. When a cell with a specific receptor finds something, it begins to make more of itself. And the populations of the cells with that specific receptor directed against that particular thing grows and grows and grows. In some people who develop autoimmune disease, there are receptors that target proteins in our own body. So in birdshot chorioretinitis, a particular type of cell called a T cell becomes excited by something it sees, and then it begins to find where those things are in the body. A lot of what excites the T cells are probably inside the eye, and it begins to slowly damage the eye. If you can't treat it or can't get the disease under control, unfortunately, over time, the disease will take its toll and cause blindness.
The proposal, comprehensive adaptive immune repertoire sequencing in birdshot chorioretinitis.
The challenge right now is figuring out what's causing it and how to treat it in a way that is safer and more effective and improves the quality of life of the patients with the disease. So the ultimate goal of this project is to understand what is happening under the hood. What is the mechanism? What are the cells in our immune system that drive this disease? We're going to look at all of the immune cell receptors to figure out which ones are associated with active disease and which ones are associated with inactive disease. And that's the first stepping stone to really figuring out what the immune system might be targeting in birdshot. If we zoom out again and look at the immune cells of our adaptive immune system that have all of these receptors, and we read all of them, we're going to get back just hundreds of millions, if not billions, of unique little snippets of what these sequences are. How do we make sense of it all? That's actually a huge problem. But now, with advancements in computation and artificial intelligence, we're collaborating with a group at Stanford University, Dr. Scott Boyd's group, who have developed an artificial intelligence approach to essentially read this adaptive immune receptor repertoire and classify immune disease. The funding by Fighting Blindness Canada will help us to actually do the experiments that can get this immune repertoire data, the sequencing data, and that's no small feat in its own. And then by collaborating with our colleagues at Stanford, we're hoping to apply machine learning, artificial intelligence, to make sense of this data, as they've shown they can do for other diseases. Applied to birdshot, we're hoping that this approach can tell us what's important for disease activity. Because once we understand what, we can start to ask questions like how, and that can lead us to designing novel treatments and therapies that are safer and more effective than what the patients have. It's maybe daunting in some ways, but it's also incredibly exciting. I don't think people have really explored this space before, and that's kind of, the spirit of scientific progress, and it's quite a, a privilege to have a chance to participate in that.
Hello, Carol. Welcome to the event. Nice to meet you. Okay, Glenn.
So you used the word daunting in the pitch. So my question was going to be, how much faster do you think AI makes this analysis? But then I guess my follow-up would be, do you think it would be even possible to do just as a human?
I don't think it's actually possible without this level of computation, to be honest. It's impossible to do manually, and I don't think it's easy to do at all, by conventional methods that existed previously.
I just want to know, a little bit more in details how you're going to do this. So I'm assuming you're taking blood samples from patients and you do single-cell sequencing of their immune cells?
So we got funding from FBC in 2022 to essentially do single-cell sequencing in birdshot. And what we've established to actually do this is essentially a multi-center prospective study where we follow patients over time. They come into the study with active disease, we treat them, and at every point we collect a sample. We also have them go essentially a battery of tests that allows us to link the biological sample to whether they're active or not.
One question from me, how did you connect with the US researchers?
So it just so happens my brother is currently a computer science PhD student at Stanford. We would talk at dinner, and eventually ideas converged.
Okay, so you have to get your US colleagues to vote for you by donating, and in US dollars it's cheaper, right? Right? All right. We've all heard these incredible vision research pitches, each one with a slightly different approach and tactic to fighting blindness in Canada and around the world. Again, our big winner will earn the FYI Doctors Research to Watch Award and get $25,000 to help take their vision research project to the next level. Now it's time for our 3 in-studio judges and our Academy members to vote for the winner. But for a minimum $50 donation, you at home now have a chance to vote for the $15,000 Heathbridge Capital People's Choice Award. Here's how. Simply visit fbceyonthecure.ca and make a minimum $50 donation, and you'll have the opportunity to select and vote for your favorite research team. Voting will be open until noon Monday, November 20th. Even easier, you can scan the QR code on your screen right now with your camera, visit the site, make your donation, and then cast your vote for which project you found most exciting, which one inspired you the most or left you wanting to learn more. And be sure to follow Fighting Blindness Canada on Facebook and join us live on Tuesday, November 21st at 3 p.m. Eastern Time. That's when we announce the People's Choice Award winner.
As Canada's largest eye care provider, we couldn't be more proud than to align with a group that has played such a role for so many years in prevention of blindness. FY Doctors is committed to the training of optometrists, not only through our organization on a day-to-day basis, but through investments that we've made in the universities. Our innovation labs have taken training of optometrists to a new level. It's exposed them to eye disease that they just normally wouldn't see in the normal course of training. Our state-of-the-art manufacturing facility in Delta, British Columbia, making very, very high-tech individualized lenses. It's an evolving profession with evolving treatments, technologies that gives you an ability to give back to people in a very, very significant way. So to be able to say that you have helped a person see better is quite something to be proud of.
So now, the big moment. We have all 5 project finalists live with us back here on the big screen for the announcement of the winner. We've had the voting for the first prize, and here is Glenn to announce the winner.
Yeah, so to, I guess, sort of give away the answer, we used AI to calculate the voting. I'm very happy to congratulate Carol for winning the Researcher to Watch Award. Congratulations. No, I mean, certainly everybody had a great presentation, and thank you all for participating. FYI is really happy to work with Fighting Blindness Canada to help fund research that's going to help all Canadians for years and years and years to come. So congratulations, everybody.
Thank you to Fighting Blindness Canada, the judges, and the Academy for selecting our project as the winner of Fighting Blindness Canada Iron the Cure competition. We are so privileged, humbled, and excited to finally have the resources to make this project a reality. Over the coming months, the team will be working very hard to start recruiting patients and collecting samples for this study. Thank you for the privilege of participating.
We want to give a special thank you to our judges, Glenn, Michelle, and Ramya, for joining us tonight, our reception partner, Bachner Eye Institute, and our registration partner, Dealey Group, and of course, our esteemed Academy members and all of our special guests. And a big thank you for watching, for donating, and for voting. Please know that you are making a huge difference in the fight against blindness by supporting the important work of Fighting Blindness Canada in its efforts to produce research, education, and advocacy. Please visit the website fightingblindness.ca to learn more about all of the important vision research, education, and additional work that's being funded by Fighting Blindness Canada, and to donate today. With your support, vision research will continue to drive treatments and cures for a brighter future.